chúng ta sẽ được nghe báo cáo thứ hai. Tôi cho là một cái báo cáo rất hay vì các cái dấu ấn mới, các cái xét nghiệm mới có giá trị trong chẩn đoán theo dõi điều trị cái ung thư gan mà lại có trên nền của viêm gan B. Thì cái này mang cho các nhà nội khoa và các nhà cận lâm sàng và các cái nhà điều trị nói chung. Thì sau đây xin mời báo cáo thứ hai bắt đầu.
Thank you, Chairman, for your kind introduction, and I really appreciate the organizing committee of this wonderful symposium in Vietnam. I will talk about the current and new biomarkers in HBV infection associated with hepatocellular carcinoma. This is my COI. Today, I will talk about the two main body of story, the current biomarker and new biomarkers of HBV-related hepatocellular carcinoma. This is the table of content. I will start by introduction. High prevalence of hepatocellular carcinoma in Asia is strongly associated with HBV infection. You can see the red and orange part around the world that indicate a very high rate of HCC occurrence. These parts mostly include Asia and Africa, where HBV infection is endemic. Therefore, the control of HBV infection is crucial to prevent hepatocellular carcinoma development. Early diagnosis of a hepatocellular carcinoma is very important to make patient prognosis be better. The most guidelines recommend ultrasonography with alpha-fetoprotein, AFP, which is a traditional tumor markers as a HCC surveillance modality. However, the ultrasonography only is not perfect for HCC surveillance. The accuracy of ultrasonography is superior to alpha-fetoprotein only, but not so ideal. The sensitivity of ultrasonography is from 65 to 80%, and specificity is over 90%. This accuracy issue can be explained by technical problem. It is very difficult to find regions of blind area like a liver dome and peripheral area and infiltrative type of HCC by ultrasonography. Therefore, the need for tumor biomarkers are continuously increased. This table summarizes the HCC surveillance guideline in Asian countries. Especially the Japanese guideline recommend 3 tumor markers, including alpha-fetoprotein, the PIVCA2, and AFP-L3. I will discuss these tumor markers later more in detail for high-risk patients for a 6 months interval. There are several factors determining the prognosis of hepatocellular carcinoma. Those factors are tumor factors, which include tumor burden, number, and presence of vascular invasion, and extracellular metastasis or tumor pathology, on-treatment response evaluated by imaging. And lastly, tumor marker level. Diagnosis is also very, very important to predict the tumor prognosis. Biomarkers in HCC are usually molecules directly produced by cancer cells or as an effect of a tumor on healthy tissue. Besides, there are serum proteins, oncofetal antigen, hormone, metabolite receptors, enzymes, or genetic materials. Above all, ideal biomarker should have high sensitivity, high specificity, and good correlation with the tumor progression and the prognosis. Let's look at the current biomarker for HBV-related HCC. As you know, alpha-fetoprotein is a representative tumor marker of HCC, which is elevated in 50 to 80% of HCC patients. However, as it reflects hepatocyte regeneration, it is not specific to HCC, and it can be elevated in benign situation like chronic hepatitis or cirrhosis as well. In addition, the role in early detection of HCC is limited because of low sensitivity of alpha-fetoprotein. This study was conducted in our center. A total of 392 patients with cirrhosis were regularly followed up. The combining alpha-fetoprotein and ultrasonography increased both sensitivity and specificity of HCC detection. This combination is superior to the alpha-fetoprotein only or ultrasonography only. In a Korean study, a total of 1,255 patients with chronic hepatitis B were retrospectively enrolled. PIVCA2 DCP might be better tumor markers than AFP. When it combined with alpha-fetoprotein, the early detection of a hepatocellular carcinoma was enhanced. Based on the meta-analysis of 27 studies, the diagnostic performance of a combination of alpha-fetoprotein plus PIVCA2 is prominent to that of either biomarker alone in detection of HCC. So I highlighted that both tumor marker combination is better than one either. I will share the data from our center of Yonsei University. A total of 702 patients with compensated cirrhosis were regularly followed up. Among them, 307 patients were available of both alpha-fetoprotein and the PIVCA2 DCP, which were measured every 3 months. After excluding the patient with protocol violation, a total of 176 patients were finally analyzed. During the follow-up, 24 patients developed HCC. This table shows the characteristic of 24 HCC patients. Most of them are BCLC stage A. At diagnosis, 54% of patients had alpha-fetoprotein greater than 20, and only 21% had alpha-fetoprotein greater than 200. Similarly, 58% of patients had a DCP, PIVCA2 greater than 40, and only 29% had a DCP greater than 150. The half of patients showed a positive ultrasonography finding at diagnosis. We learned from these findings that tumor markers or ultrasonography only is not sufficient to detect HCC completely. Alpha-fetoprotein by itself showed the highest specificity but low sensitivity. PIVCA2 had a slightly higher sensitivity compared to alpha-fetoprotein alone. The best cutoff value in this was around 8 in alpha-fetoprotein and 38 in PIVCA2. This is another study from our Yonsei University. Consecutive 1,447 HCC patients were assigned to 4 different groups according to the cutoff value of both tumor marker, alpha-fetoprotein 400 and PIVCA2 100. 4 groups consist of both tumor markers high or one of tumor markers high or both tumor markers low. So these 4 groups. Okay, you can see this graph showing the cumulative survival rate according to the groups. The overall survival rate showed a significant difference among the 4 groups. The group of tumor marker low had a favorable outcome, and the group of both tumor markers high showed the poorest outcome. The PIVCAT2 level indicate the poor prognosis compared to alpha-beta protein levels. The 5-year survival rate was only 11.5% in the group of both tumor markers high level. It reflects that the baseline alpha-beta protein and PIVCAT level might be helpful predicting tumor prognosis. Significant differences in survival among the 4 groups were identified in each TNM stage as well. The low baseline level of tumor marker predict better survival in TNM stages 1, 2, 3. However, in stage 4, tumor markers are not useful to predict prognosis due to the very short survival of patients. We also investigated whether preoperative tumor markers can predict HCC recurrence after curative resection. 267 patients were divided into 2 different groups. The group pre-op 1 defined as both tumor marker elevation, alpha-beta 14 and PIVCAT2, and the group pre-op 2 had only 1 tumor marker elevation or both tumor markers very low. The pre-op 1 group, which is a both tumor marker elevation, associated with a higher recurrence rate and the shorter disease-free survival after curative resection. Therefore, the combination measurement of these tumor markers before surgery may be a prognostic factor for future HCC recurrence. A subfraction of alpha-beta protein called AFPL3 has been used as a diagnostic and prognostic marker of HCC. Alpha-beta protein L3 is secreted by malignant HCC cells in the early tumor stage, even in the absence of elevation of alpha-beta protein. Therefore, alpha-beta protein L3 levels make it the promising early screening tool. In addition, the new generation of assay has enabled the accurate measurement of AFPL3 percentage at very low alpha-beta protein concentration. AFPL3 can be detected in very low level of total AFP. Several studies showed high sensitive AFPL3 is a good biomarker for the diagnosis of HCC, even at low total alpha-beta protein level. This Japanese study demonstrated that the high sensitive AFPL3 is useful for detection of HCC in patients with a low AFP level. The sensitivity of a high sensitive AFPL3 in stage 1 and 2 were around 35% and 42% respectively. The combination with DCP improved the sensitivity compared with the AFPL3 alone or DCP alone. Even the patient with a normal AFP level less than 10, the diagnostic rate of HCC is still high in combination of these 2 tumor markers. This is an interesting study that showed the usefulness of AFPL3 to predict HCC recurrence after curative treatment. A total of 414 HCC patients who underwent resection or RFA were investigated and prospectively followed up. There were significant differences in recurrence-free survival between the groups with and without AFPL3 elevation before and after treatment. AFPL3 elevation before treatment and sustained elevation after treatment were predictable of HCC recurrence. Therefore, the repeated measurement of AFPL3 could be performed for HCC recurrence surveillance after curative treatment. This is our retrospective study investigated the effectiveness of tumor markers in detecting HCC in cirrhotic patients. The AUROC, you can see the right side of the curve. The AUROC for combination of 3 tumor markers was superior to that of any one of tumor markers alone. If HCC patients have many of elevated tumor marker diagnosis, their cumulative survival rate lowered over time compared to those with none or smaller number of tumor marker elevation. The number of tumor marker present clearly reflect the extent of HCC and patient outcome. Let's move on to the new biomarkers. This table is for early HCC detection regardless of underlying disease. Today, I'd like to introduce hepatitis B virus correlated antigen, which might be one of the new biomarkers, especially in patients with HBV infection. HBV core-related antigen consists of 3 pre-core protein products: hepatitis B virus core antigen, E antigen, and 22 KD pre-core protein. Theoretically, all protein components are translated from CCC transcript. Therefore, the core-related antigen exclusively reflects CCC DNA transcriptional activity. There is only one commercial core-related antigen also available from Fujilabio company in Japan. Core-related antigen can be used for various purposes in treatment, naive and antiviral treated patients with chronic hepatitis B. The lower core-related antigen are associated with favorable outcome. Recently, the role of core-related antigen as a tumor biomarker has been highlighted, especially in HBV-related HCC. The core-related antigen may complement HBV DNA level to predict HCC development. The predictive value of serum core-related antigen for development of HCC in treatment naive patient was firstly reported by Tada et al. In Japanese study. Core-related antigen level over 2.9 log was associated with more than 5-fold increase in HCC risk. And together with the Hong Kong study, the Taiwan study was the largest among E antigen negative patients. Higher core-related antigen over 4 log was associated with more than 6-fold increase of HCC risk. Again, in a Taiwan study, more than 2,600 patients with HBV infection, core-related antigen level is an independent risk factor of HCC. The core-related antigen level of 4 log identified the high risk of HCC, especially in patients with intermediate viral load. In patients receiving prolonged antiviral therapy with profound viral suppression, HBV DNA and S antigen level no longer serve as a HCC predictor. However, the several studies suggested on-treatment core-related antigen level may remain as an HCC predictor. The high on-treatment core-related antigen level are associated with increased risk of HCC development. This is a very nice review paper and tables from the clinical and molecular hepatology. Ladies and gentlemen, now I'd like to conclude my talk with these take-home messages. The level of alpha-beta protein correlates with HCC burden, tumor burden, but its role in early detection is still limited. there's a low sensitivity as well. PIVCA2 might be a better tumor marker than alpha beta protein itself, and the combination with alpha beta protein PIVCA2 may enhance early detection of HCC. The highly sensitive AFP-L3 is a novel biomarker for HCC. The combination of 3 tumor markers is superior to that of any one of the tumor markers alone. Lastly, the core-related antigen is expected as a new biomarker for prediction of HCC development in treatment-naive and antiviral treated patients with chronic hepatitis B. I really appreciate your kind attention. Please keep your health against COVID-19 pandemic. Thank you very much again.
Rất cảm ơn giáo sư An của Hàn Quốc. Tôi cho là một bài rất hay về các cái xét nghiệm, đặc biệt các cái dấu ấn mới để trong cái chẩn đoán theo dõi cái điều trị ung thư. Mà ở đây giáo sư có nhấn mạnh cái vai trò của alpha HBV và DCP, tức là PIVCA2 đấy. Và đặc biệt là có nói cái giá trị theo dõi cái tính tái phát tiên lượng của cái HBCR-AG. Thế thì những cái cũng rất là mới, thì cho những nghiên cứu rất hay. Trước đó chúng ta nghe của một giáo sư Singapore với tư cách là chủ tịch cái hiệp hội gan mật tụy châu Á Thái Bình Dương, còn đây là của một giáo sư chuyên sâu của Hàn Quốc của đại học Yonsei. Thế thì có rất nhiều cái phần hay, nhưng mà tôi vừa hỏi thì cả hai giáo sư đều đang vướng, không dự trực tiếp được, thì chúng ta sẽ chuyển ở cái phần thảo luận phía sau. Thì sau đây thì xin mời phần điều hành tiếp theo của giám đốc Phạm Minh Đức, và tiếp theo của giám đốc Phạm Minh Đức là sẽ là tiến sĩ Vũ Quốc Bình điều hành tiếp.
Kính thưa các vị đại biểu, kính thưa các thầy, các cô, các anh chị và các bạn đồng nghiệp, thưa toàn thể hội nghị. Hôm nay Bệnh viện Quân y 34 được tổ chức một cái sự kiện rất lớn của Hội gan mật Việt Nam. Chắc chắn là trong phần tổ chức và trong phần điều hành không tránh khỏi những cái khiếm khuyết. Bởi vậy chúng tôi rất mong nhận được sự lượng thứ. Kính thưa hội nghị, trong những năm qua, Hội gan mật và phân hội phẫu thuật gan mật